labeled as long haul patient of COVID. And so long haul is more like, the post-COVID syndromes. Some people have, some don't, after 4 weeks, 8 weeks. And don't quote me, but I think Dr. Roy would be telling us exactly what he has seen in his patients and what the world believes in. And it'll be a very, very interesting topic. And Dr. Narayana is from Boston, from the Brigham and Women's Hospital, but today he's in the capacity from the organization he runs on public health literacy. And I will not take much time, and because it's a very important topic, and I hand over to Dr. Roy. Thanks.
Thank you. Thanks, Anil. Thank you all. It's such a pleasure to see all this esteemed speaker here. My name is Narayana, as Anil just mentioned. I work at Brigham and Women's Hospital as a technical director. I'm also co-founder of Public Health Literacy. We are very pleased to have Dr. Sitesh Roy, who is a US board certified immunologist and asthma expert. He's also founder of Dr. Roy Health Solutions, a multi-specialty clinic in Mumbai. He has a vast experience working in developed countries in different states, in Chicago, Mississippi, Washington, also in India, where the COVID has a significant effect. The purpose of this webinar is to talk about long COVID. As we all know, it's a very emerging term, and we are looking forward to hear from Dr. Sitesh. How do we define, as public health experts, long COVID? What is its implication as the definition begins to shape, and kind of put a perspective, how does this long COVID affects subgroup of people who have been hospitalized, sick, and recovered from the acute COVID and living with the potential risk of long COVID. And the another group is who have been positive, just like Anil mentioned, who are not symptomatic, who are just positive, and they're living with that fear of what is the effect of long COVID. And the third group is people who don't know they have COVID, like someone like me. I have been negative until 2 weeks ago, but I could be potentially positive. I don't know what's the effect. So these are the three different groups I'm looking forward to hear from Dr. Sitesh. More importantly, as a physician, the symptoms of long COVID hits across all organs. We're talking about shortness of breath, which is lungs, chest pain, which is heart, and sore throat, which is throat, and mental illness, cardiomyopathies, and a significant amount of neurological implications. And we also want to hear, what does it mean to people who have pre-existing conditions, who have been suffering from chronic diseases, dialysis, transplant subjects, organ failure subjects. And lastly, we also want to hear, how does this affect we as a global community, and also community who are vulnerable, and what is the future moving forward for us? Dr. Sitesh, please take over, sir.
Thank you very much, Dr. Narayana. Thank you, Dr. Anil, again, for kindly having me over. We've done several of these through the COVID scenario, and this one being another one of them. Just going to share my screen and begin. So I think as the topic has been laid forward, just give me a second. For some reason, the window closed down on me. I'm just reopening the window and shall get going in a second. But as has been mentioned, this topic is a very tricky topic, as I may say, because there is still so much we have to learn about long COVID and what its implications are, and what it means for people. I think you all should be able to see my screen now, right?
Yes, we do see, Dr. Sitesh.
All right.
Yes, it's clear. Yep.
just getting an overlap on this from some other screen. Okay. Um, so we have known that this is the beta coronavirus that we've been dealing with, this virus that showed up in November or December, depending on which theory you believe, of 2019 and became clear in 2020. Is a virus that belonged to the family of the SARS and MERS and clearly had very unique features to it that has left us with a lot to learn over the last 2.5 years. Um, the various features of it, such as being transmissible in the pre-symptomatic and asymptomatic cases, having variants that have led to anywhere from 3 to 5 waves across the globe, and has affected over 500 million people across the world, is really something that has been a very incredible, is the only word, uh, disease that has left all of us with a lot to learn. When we talk about acute COVID, which we've heard can be asymptomatic, pre-symptomatic, symptomatic, and then affects the upper respiratory tract, then the lower respiratory tract, and can sometimes skip all of this and directly affect the gastrointestinal tract, and then can affect any organ system in the body. And the virus, the SARS-CoV-2, has been detected in literally every single body fluid that you can think of, suggesting that this virus, through a variety of different mechanisms, whether it's through the ACE2 receptor, whether it is through endosomal fusion, there are many different mechanisms by which, whether it's through the neuropilin receptor in the nervous system, it has variety of ways by which it truly transmits and goes through the human body. And the way I would look at this is, depending on where, what I call, over my experience in the medical field now for the past 32 years, right from being a medical student till now, wherever is the weakest link in the human being's body is where the virus seems to attack the most. And then it can also create new manifestations, and it can unmask things that we did not know existed but were in a subclinical phase, as we will see. But clearly, with the manifestations of something like the Delta variant, which had more of lower respiratory disease and a lot of hospitalization, death, um, we've then moved on to the Omicron variants, which have more upper respiratory disease, but then in unvaccinated individuals and sometimes also in vaccinated individuals can cause just as much havoc. And as we are seeing the BA4 and BA5 variants, which are becoming more and more implicated in lower respiratory disease, whereas the Omicron BA1, 2 variants were largely limited to the upper respiratory tract and some systemic symptoms. So really there is so much that is going on in this virus that we have to realize that from the acute phase, where any organ system in any combination can be affected, fever being present, not present, cough being present, not present, shortness of breath reduced a lot during the Omicron variant. So there is a lot that is changing. When we look at the usual course of this disease, we come to realize that from the time of exposure, symptoms may begin in anywhere between 2 to 10 days, but average is around 5 to 6 days. I can say that it can even be faster than that, especially with Omicron. The lag time to having symptoms has reduced tremendously. And then from there onwards, the usual recovery time for most mild or even maybe moderate cases would be around 2 weeks. But those who get hospitalized, those who go in the ICU, those who may be going on a ventilator, may take up to 6 weeks for recovery. And this is also a very general estimate, because there are so many things about the comorbidities of the patient, the age of the patient, the underlying health condition of the patient that can determine what the person's outcome will be. But we all know that majority of patients will recover without any major issues, at least in the acute phase. 10 to 15% can go into the moderate to severe disease, and 5% or less sometimes can go into the critically ill phase. This was all true for Delta. When it comes to Omicron, the numbers are different. I would say the critical goes down to 1 or 2%, and that too largely made up by unvaccinated individuals.
Hello.
Hello.
As an immunocompromised candidate, you explained very well all the things. And we have people in my family have sore throat. Someone has a poor taste. Someone is very sick. So we are hoping, Dr. Sitesh, we do see your slide. We are hoping you can help us to put some light. How do we serologically test these subjects, patients? Please, sir, we see your slide. Our apologies for all the audience, little technical glitch. Over to you, Dr. Sitesh.
Sure. So I think some of this I have already spoken about, so I won't get into. As I mentioned, the usual clinical course is up to 2 weeks. That's the expected time for recovery. There may be some lingering symptoms that may be seen up to a month. And that's why whenever we look at the post-COVID terminology that is used, whether it's long COVID, long haul COVID, post-COVID syndromes, chronic COVID syndromes, or what the researchers like to call the post-acute sequelae of SARS-CoV-2, we are really looking at the same thing no matter what we call it by. And unless we have ways to differentiate each of these, that's what it will be. I'm going to give you an example of how the NHS and the CDC look at long COVID. So acute COVID in the NHS guidelines is 4 weeks. Ongoing symptomatic COVID is when it's between 4 to 12 weeks, and anything that goes beyond 12 weeks becomes the post-COVID syndrome. So in addition to this, the term long COVID is used to describe signs and symptoms that continue to develop after COVID-19, both ongoing and new onset. So in some ways, they are also saying that whatever lingers beyond 4 weeks is long COVID. And that's what CDC says too. So any symptoms that persist beyond 4 weeks of the illness, physical and mental included, that's what we are looking at, and they continue for at least 2 months or 3 months from the onset of the illness. And we are looking at a lack of return to the usual state of health. It's unexplained by any alternative diagnosis, and it is not related to the active viral infection. And I think this is where the query that Dr. Narayana raised about does serology help all of this? And there are situations in which I have had cases where the patient has had up to 3 negative RT-PCRs, and we have done an entire presentation on this, Anil, you might remember, where the test is negative, but the patient is COVID positive.
Sure.
Where based on the person's presentation, it was very clear, and this was actually a 13-year-old girl who had had fever and myalgia, had fatigue, a little bit of cough, a little bit of nasal congestion, recovered from what seemed to be the acute phase, but then even a month later was extremely fatigued, tired, could not study, could not focus, was having massive panic anxiety attacks, could not study, could not read, did not have the stability to do anything. And when we checked her viral titers, because the first one, it had shown a very weak positivity, we saw a rising viral titer in the subsequent 2 months. And it was very clear that though her symptoms were classic for COVID and her tests were negative, that is the infection that she had. And it was invaluable in us identifying long COVID very early and giving her the right treatment. I'll show one more case a little later of a person who also had neurological problems. Such chronic symptoms after infections are not new to us. In fact, in SARS and MERS, people had post SARS and MERS fibrosis, lung disease, dyspnea for up to 2.5 years after the infection. So we know that coronavirus can do this. Just the myriad of symptoms that SARS-CoV-2 is giving is something we haven't seen before. For example, in Lyme disease, we know that 5 to 15% of people who are infected have fatigue, muscle, joint pain, difficulty thinking that can persist for 6 months even after accurate antibiotic treatment. Similarly, myalgic encephalomyelitis, what is also known as the chronic fatigue syndrome, very well connected with Epstein-Barr virus. We know that infectious mononucleosis, also known as the kissing disease, severe fatigue, bone pain, painful lymph nodes, targeted symptoms. And I can tell you, while I worked at National Jewish in Denver, there was an entire clinic that was dedicated to chronic fatigue syndrome, and the number of cases and evaluation that we did looking at EBV or some of the other viruses causing these syndromes, and the degree of suffering that these patients had, which seemed so far out of proportion to any of their lab work, that it was really incredible to know that what viruses can do. And I think SARS-CoV-2 has woken us up in a very big way, because the numbers affected, when we are talking about 500 million documented infections, I can easily say that the undocumented infections may be double or triple than that number. And conservatively, if we take 11.5% of them have some significant long haul COVID symptoms, we are still talking about 57 million people with long haul COVID around the world, 5.75 crores. If we take the undocumented, unconfirmed cases that never went for testing and just showed up in a neurologist, a psychologist, or a pulmonologist clinic, the mind-boggling numbers are of an immense magnitude. It's well known that 1 out of 10 patients can have symptoms beyond 12 weeks. Other studies have suggested the numbers can be 30%, and you'll see in some of the slides I present a bit later that even up to 55 to 60% of patients will have some long-haul COVID symptoms, whether it be fatigue, myalgia, headaches, lightheadedness. The list is just endless, as you'll see in a second. The interesting thing is, majority of these patients in this recent study that I've mentioned here, who had long COVID symptoms persisting till 9 months after the illness, were mild cases. So clearly, unless we did serology, we would never know the asymptomatic cases. But even in the mild cases, a person can have long COVID up to 9 months. And again, those who come out of the hospital, I'm not going to go too much into detail with that, the post-intensive care syndrome that we call about, where a person has been through a critical illness. They can even have PTSD-like issues. They can have a lot more muscle and physical issues just because of being on a ventilator for a prolonged period of time, being on multiple drugs that can affect their body. So the list is really long. Before we get into what the manifestations are, why does it occur? I believe that we don't know for sure. There are many theories, nothing is certain. It's, in my opinion, a combination of factors. So when we take the severe cases, as I said, a post-ICU syndrome or a PTSD-like state can be a cause. It can be due to the body's immune response to the infection. Immune system may over respond in that area and cause damage that might be then irreversible or very slow to reverse over time. It can also trigger direct tissue injury and inflammation. There can be nervous system injury and damage that can be direct. There can be recurrent infections that occur, or there is the question, can there be a reactivation of the virus? This has been a little difficult to study. It has not really been shown, but people have raised the question, could there be, like in EBV, we have seen very low-grade chronic infections with Epstein-Barr virus, and the question comes up, can SARS-CoV-2 do that? And then, as I mentioned, unmasking of subclinical diseases and diseases in evolution is certainly something that's very important. When we look at the potential impact on any aspect of health, I'll list some of the commonest issues that have been mentioned, and I'll give more details in the subsequent slides. But dyspnea and increased respiratory effort, fatigue, post-exertional malaise, and poor endurance. This is something that is very, very prominent in some cases, where even short amount of work, even daily life activities, can make a person so tired that they will have to go lay down and sleep. Brain fog, cognitive impairment, memory issues, again, a very common issue and can lead a person to go to a psychologist, psychiatrist, family physician, their MD physician, and go all around the world trying to find a cause when it might be one of the post-COVID long-haul symptoms. Cough, chest pain, we can understand chest pain, again, due to a myriad of causes, headaches, palpitations, and tachycardia. Again, I've had several patients with this problem where either their BP shoots up without a reason, a slightest amount of stress puts them into a palpitation and hypertension crisis. Arthralgia, myalgia, paresthesias, abdominal pain, diarrhea, insomnia, and sleeping difficulties, again, can be so traumatic to a patient who has no explanation why they have just stopped being able to sleep normally. Fever that comes and go, or a feeling of feverishness, lightheadedness, impaired daily function and mobility, pain, urticaria. As an allergist, immunologist, and someone who handles acute and chronic urticaria, I have seen a large share of people, not just after infection, but I will warn you, even after vaccination, who have developed acute and then chronic urticaria. So there is something about the virus and its structure and what it does to the immune system that can do some very weird things. Mood changes, change in taste and smell. I just had one gentleman today who had brought in his daughter to see me for her follow up and said that after he had COVID almost 8 months ago, he has still not completely recovered neither his smell nor his taste. And I have many other cases that have gone even past a year sometimes. And there are many theories again on what happens to the olfactory bulb in these infections and why this problem occurs. Menstrual cycle irregularities. One thing not mentioned here, which I think is there on a subsequent slide, but hair fall has been so incredible in some people that it has led them to requiring hair transplants. They have lost that much amount of hair in a short span of time. This is just an extension. You will see post-COVID ILD added on this list. You will see persistent COVID toes, erythematous rashes, depression, anxiety, social isolation, heart failure, myocarditis, pericarditis, and then peripheral neuropathies and peripheral limb ischemia, all of which long after the disease and virus is gone. Over 50 symptoms have been described of long COVID. And within this, you can see the number of people reporting it can range from 58% having fatigue to 44% having headaches to 24% having shortness of breath, depending on the study you look at. Very interestingly, you will see 11% with sleep disorders, 16% with memory loss, 11% with ongoing pain. Pain can be involved in any area of the body that can potentially be, as I said, their weakest link. If they had an existing back pain or a neck pain or a shoulder pain, it can potentially then even affect that area of the body and cause a lot of problems on an ongoing basis. When we go system wise, again, there is a lot that is mentioned here. I won't get into it, but when you get down towards the urologic symptoms, you'll see that incontinence, urinary incontinence, suggesting that the autonomic dysfunction can be immense, sexual dysfunction. So there is no part of the human body that potentially does not get affected by this virus and what it does in its aftermath. Are children at risk for long COVID? Interestingly, the range can be 0 to 13%. So in some studies, they found no children with a problem. And in others, they found that fatigue, shortness of breath, difficulty concentrating. This 13-year-old girl that I mentioned about, she had such bad loss of concentration that she was not attending any of her classes. School wasn't even able to pick up a book and read. She would start trembling. She could not concentrate. She could not read. She would suddenly get double vision. And this was 6-8 weeks out from the infection. This may resolve in children faster, but this young lady required treatment with neurological therapies as well as with anti-anxiety, anxiolytic medications, and is actually doing fantastically well now. So children do get affected. There's something called the multisystem inflammatory syndrome, and it can occur in children. So it's called MISC. C and then MISA, which is for adults. And again, this can be after a period of being normal, then having fever along with stomachache, diarrhea, vomiting, skin rashes, bloodshot eyes, dizziness, lightheadedness, can lead to hospitalizations. We've always known Kawasaki disease in children, which is a classic example of an MISC. Post-viral infections, we've seen the same thing again and again with COVID. People often bring up this question, is there a difference in the long haul COVID between the Delta, Alpha, Beta variants and the Omicron variants? And interestingly, some studies done recently suggest that the long haul COVID was somewhere around 11.5%, as I mentioned earlier, in the Delta and the previous variants. And in the Omicron variant, it was found to be about 4.5%. So I think though the number of people getting long haul COVID is less with Omicron, the volume of infections that Omicron has given around the world, I think I would say that 80% of India was sick within that wave in the first couple of weeks of Jan and Feb into early March. And you can only imagine 4.5% of that volume of people would mean a massive long haul COVID that people are now suffering with and living with. How do we evaluate such people? What are the basic diagnostic tests? Obviously, the blood counts, the electrolytes, the renal functions, we want to know what's happening in their metabolism, because sometimes it may not just be that, it may be something else that has developed. A simple urine report, a liver function test with a metabolic panel, inflammatory markers. In this young lady, 13-year-old girl that I mentioned, her C-reactive protein was in the 50s and 70s, again, several weeks after her infection had settled down. And her ESR almost took 2 months to come down, and we were treating her with anti-inflammatory therapies. But ultimately, it was the neurologic therapies that were key for her. Ferritin, because it can also stay elevated. Free T4, TSH, vitamin D, B12, because optimizing these two can definitely help reduce the manifestations of the disease. Rheumatologic workup, including an ANA rheumatoid factor, the anti-CCP, anti-cardiolipin, CPK, the D-dimers, fibrinogen, troponin, when we are looking for cardiac injury, myocarditis, ongoing cardiac issues, the B-type natriuretic peptide, if we suspect cardiac involvement. There is also an immense impact on work, and I shall come to this later, but in some surveys that were done through several studies, 84% with limited activity, 81% with brain fog, 85% with persistent fatigue, 49% difficulty handling stress or doing basic tasks. I've had patients who've had emotional outbursts. They just would start crying. They said, we were never like this in our life. And now the slightest thing, and we go into this entire emotional breakdown, as they call it, and are unable to cope with the daily life activities. When the limit on intensity and duration of work was seen, affected the ability to work in 75%, 60% had to take time off due to long COVID, and 45% of the sufferers will return to work in a reduced capacity. Again, we've had several of these. We've had patients who've now, after COVID, not been able to go back to their office duties. They're still working from home because that's the only way they can keep their job. What do we do in terms of, besides the lab work that I mentioned? Functional testing is very, very critical to know. A 1-minute sit to stand test, a 2-minute step test, a 10-minute walk test, a 6-minute walk test. Remember that there are some patients who may refuse to do this because after they have done a 6-minute walk test, they may not be able to walk for the next 3 weeks. And that's the degree of disability that they have developed in their muscular neurological system, that even doing the test can incite an entire episode of inflammation and post-inflammatory changes in their body. So doing these tests also, you have to be very careful about listening to the patient. These people are not lying. There may be always some malingerers, but we will have to pick those out as physicians and better understand them. A balance scale, other tests like a tilt table test, because there have been a lot of people who've had orthostatic hypotension. Just going from lying to sitting or sitting to standing can make them extremely disoriented, dizzy, tachycardic, and other issues, and even to the point of having falls sometimes and injuring themselves. Functional status and quality of life being evaluated by various questionnaires and scales that are there. The respiratory conditions being evaluated by the MMRC, the neurologic conditions managed through the mental status examinations, the neurobehavioral symptom inventories. All of these are available online and through various resources, which I will also give at the end of my talk. And using these become very important when screening patients, when everything else seems to be going nowhere, as I may say it. Psychiatric symptoms, the generalized anxiety disorder, the patient health questionnaire 9, the PTSD symptom scale, the post-traumatic stress symptom scale, screen, the PTSD checklist. There's a long list again. When it comes to other things like the Wood mental fatigue inventory, the fatigue severity scale, the insomnia severity index, the connective tissue disease screening questionnaire, all of these have been used a long time for our CFS, our chronic fatigue syndrome patients, and also for our autoimmune rheumatologic patients. But now they are very, very useful even in our post-COVID or long-haul COVID cases. I'll just present a brief case here, a neurological case, a 20-year-old lady who had COVID 5 weeks ago, recovered completely except for some fatigue and mild headaches, and now presents with what is a generalized tonic-clonic seizure, fits that she was having, as it's commonly called in India, not a right word, but It's basically seizures that she had, was admitted, required to be stabilized, and then later on it was found that uh, she was given steroids with some partial improvement, knowing that this could be an autoimmune manifestation. Intravenous gamma globulin was given to her. Subsequently, rituximab needed to be given, which is a B cell agent, as you are aware, to reduce immunoglobulin. Again, IVIG infusions, and over a 2-month period, she had complete recovery with just mild lower limb weakness. So there have been a lot of cases like this that my neurologist colleagues have seen, that we have referred or they have then shared with us during our common panel discussions, where we have tried to figure out how to best manage these cases. A very interesting question that comes up is, does vaccination affect the risk of long COVID? And it's a very interesting question. Initially, data that came from the UK, 1 million people who were entering their feedback into a system, uh, shared that they suggested that there would be lower odds of symptoms lasting more than 28 days in vaccinated people. Other studies also suggested that vaccination may improve the severity of symptoms. There have been some case reports where people have said that after they took the vaccination, their long COVID actually reduced, their symptom manifestation reduced. But now, finally, a study from the VA system in the United States, where 13 million people very carefully studied and follow in that system, found that vaccination lowers the risk of long COVID after infection by only about 15%. What does that mean for all of us? It means that limited protection can be provided by vaccines. It's not that they don't work, but as the variants are changing, as the Omicron has very smartly learned with its over 50 mutations to evade the immune response that vaccines and previous infections are providing, withdrawing measures like mask mandate, social distancing, might be putting people who are especially at risk with immunocompromised or major immunocomorbidities at risk for developing the infection, and then eventually for developing a long haul COVID thereafter. What is the role of public health in all of this, knowing the data that we have right now? Some of this is from the CDC, some of this is from the NHS, but ultimately the guidelines and the recommendations remain the same. We are still not out of the COVID pandemic, as you may call it. You all have yourselves in the US seen cases over 2 lakh per day, many of them mild or very mild, but still present, and amongst the unvaccinated, still hospitalizations, though at a much lower rate than they were in the Delta variant phase, but the volumes are huge. So I think wearing a mask, and especially for those with comorbidities or with other risk factors, or those who are already dealing with a long haul COVID, becomes very, very important. Maintaining physical distancing, especially from people not from the household, avoiding crowds and poorly ventilated areas. Tell me about this, living in India and having patients who travel by the Indian railways or with the Indian bus system or any of the other public transportations, where people are just packed in together, which is why these viruses go through massive waves together and then disappear very quickly. Washing hands, but not obsessively, getting vaccinated and boosters. I believe in more of a mix and match booster system, though I know the Indian system currently says you get the third vaccine as the same one as you got earlier. I believe as an immunologist that mix and match strategies work better because the immune system gets something different to respond to. And certainly in vaccination, what we really need is what Pfizer and Moderna is working on, which is the Omicron variant vaccines. And we'll have to see how much that influences the long haul COVID. So those studies are easily a year or two away. Getting the annual influenza and pneumonia vaccination, so you don't have a second whammy on top of one, which would be the long COVID or the long haul COVID, and then you get a flu on top of it, or you get a bacterial pneumonia on top of it, would be a bad idea. So I think in these cases, we have to seriously consider protecting them from other infections that we can, and then being vigilant and monitoring them for long COVID and its timely diagnosis and management through an awareness. And even in my practice, I have seriously considered starting what I would call, and this has become a norm in many parts in the US, of starting a long COVID clinic or a chronic COVID clinic, where people with these problems can come in, get all the right diagnostics and treatment. Obviously, I'm doing it currently on a case by case basis, but there are places where dedicatedly half a day or a day is kept for only these cases. And I think it makes a lot of sense to do that depending in the hospital system. If different specialties are seeing this problem, they may come together in one clinic where you have a pulmonologist, you have a neurologist, you have a internal medicine specialist, you have all the specialties, physiotherapy, occupational therapy, a social worker together, and have a clinic like that that can really help these people better. We clearly have a lot more to understand. We have to understand that those with and without underlying chronic medical conditions, how they behave differently. I can tell you certainly that people who were even without chronic medical conditions, those who didn't have diabetes before they got the COVID became diabetic. Those who didn't have, as I said, panic anxiety before started developing these. So there is a lot that we have to learn. And there have been people with chronic medical conditions who have not had as much trouble. I can certainly tell you that in asthma and allergy, for patients who were on medications, they had less trouble than the ones who had uncontrolled disease before the onset of the illness. And in fact, those on inhaled steroids, antihistamines, Montelukast, tended to do better than the people who were not. And there is research and follow-up data to suggest that. So I think somewhere certain comorbid conditions uh, uh, indirectly became a protector, and some made things worse. So I think there is no generalized statement that can be made about something like this. We need to know what the effects are, how long they persist, what problems may affect, what are the clinical course, likelihood of recovery, implication for long-term health effects and return to work, and what protective measures might be used to prevent this. So we know the health effects, we know the work effects, we know that also socio-economic effects are immense. People have sometimes lost their jobs, they haven't been able to go back to work. If they've gone back, they've had to go back in a part-time capacity rather than a full-time capacity. If that's the breadwinner in the family, that has affected the entire family. I think that the implications are immense for what long haul COVID has done around the world. And I think returning to work, for many, it is a case of returning to work with long COVID, not after long COVID, because worklessness kills. So return to work has to be facilitated. Workers may not need to be 100% fit to work, and it's important for the people who are hiring them or who they work with to understand that work is an important part of the recovery process. And if they work, they get into a better frame of mind, they get into a better frame of physical health and confidence, which actually can go a long way in helping them recover. Planned supportive care, coordinated care, a multidisciplinary approach, like I mentioned, a case by case management, risk based approach, phased approach to return to work, shorter days, part time work, flexibility, accommodation, all these will help people who are really struggling. These are some of the resources that I would suggest people who are truly interested, people who are from the public health scenario and want to put up clinics or create settings where they can do a lot more. There is some amazing amount of data and information out there. There are some really good support groups, as I have mentioned, and all of these put together can go a long way in helping these individuals with long COVID, who we will only see coming out more and more over time when we are able to uh, delineate the timeline in which their problem has developed. For example, the 13-year-old girl that I mentioned, she had been to several pediatricians, and she had even been labeled as being someone who was a malingerer before she came to me. She used to see me for asthma allergy. That problem was doing very well, so they had not thought of seeing me as an immunologist. But when they were at their wits' end of what's going on with their daughter, they brought them to me, and that's when we did the serial serology looking at what was there, and we were able to identify that that's what we are dealing with, and it went a long way in helping that one patient get back to life. People often ask me, Dr. Roy, how can we prevent long COVID? You all are all familiar with this, multi-million dollar record breaking movie called RRR. I would say the RRR came out at a very right time, and what it means is rest, relax, and rejuvenate. I have seen too many people in COVID try to get back to work, try to get back to gym, try to get back to exercise too quick after the infection. And they don't give their body, which has been through a major, what I would call insult, time to heal. And this is one of the biggest mistakes that a person can make, even with mild COVID, because if you don't give your body the time and something goes wrong, then it gets very hard to reverse that. And I think that besides this, having a holistic approach where we are talking about a way in which we can really boost a person's immune system and get them back to good health, fresh air, sunlight, a healthy, fresh diet, exercise, restful sleep, where people believe in yoga and pranayama, supplements where it's recommended. And as I said, under medical supervision, vitamin D, zinc, vitamin C, a positive attitude, mindset. And I can't tell you how much prayer and meditation, because I'm a very big believer in that. And I actually work with some groups where we do this. It has gone a very long way in helping us work with primary prevention and also with a holistic healing plan where we conduct these kind of health and wellness camps and work on a person's mind, body, and spirit to get them out of these problems, because there is so much lack of confidence sometimes in these individuals that it is unbelievable what can happen. People who are keen to understand this better, I have even come to the US and done these camps before COVID. I continue to do them in India because I haven't traveled back, but this is something that can be organized and done and can go a long way, not just helping the long haul COVID individuals, but also other people. So with that, I kind of end this talk. I again thank the JSPH team, Dr. Anil, Dr. Ashish, Dr. Narayana for this opportunity to share some of my insights and experiences. I have put a lot out on COVID on my YouTube channel, Dr. I Health, and I continue to do that. I also have an Instagram handle on which I do a Twitter handle. So people are welcome to connect with me there. So with that, I shall end. We shall have some time for discussion and questions. Thank you very much once again.
Thank you, Dr. Sitesh. Thank you. It's a very fascinating and also very intriguing presentation for all of us. And I like the way you told us the story. You spoke about scientific evidence. You talked about all the testing you could do in biotesting as physicians. You also talked about some of the common sense public health measures humans can take. And I really loved the way you kind of ended the story with a more holistic health approach, which kind of empowering every part of the community. In the interest of time, I do know there is few questions. Gaurav has asked some question and B. Satya has asked a question on gut health. In the interest of time, I strongly suggest to reach out to Anil and Jodhpur School of Public Health. It should be fairly easy to reach out. Just to keep the panel discussion more robust, I will give 30 seconds if any of the panels who have a powerful question to ask Dr. Satish to end this. 30 seconds, please. And Sudhi,
Yes,
Dr. Anil, Manoj, please go ahead.
Can I ask one question quickly?
Yes, please. Yes. Please.
Dr. Sitesh Roy, what do you advise regarding Paxlovid or ritonavir, any of these protease inhibitors? Because in the US, the FDA has approved for emergency use. And I have had a couple of my relatives or friends who come from India and other parts of the world in Boston right now, and they're taking it actually because this is how it was. And so I'd like to hear from you. And also I'm due for my 5th vaccination this week, actually, the 3rd booster, which will be my 2nd booster being immunocompromised. So I'd like to hear about the protease inhibitors, if you could tell us.
Sure, sure.
And are they available in India or not?
So following the data that we know, there has been use of it off-label even prior to this. We've known ritonavir right from the beginning of the pandemic, but in a combination in the way it is available now, that was something that was new and unique. Obviously, we had a lot of experience with it with HIV and what it does to that kind of a chronic viral syndrome. So I believe that there is a role and a benefit to these. I do believe that the monoclonal antibodies, especially the ones that you received during the Omicron variant infection, do help individuals who are at risk. And I believe they need to be used what I would be calling in a judicious way. I don't think it needs to be given to any and everyone, because so far we have no data to suggest that taking any of these agents can potentially prevent someone from having long COVID. We don't have any data on that at this point of time. It would be very interesting to know if a group of patients could be followed who have been treated and not treated and follow them for long COVID. That's a study. I know some places studies like that are being looked at, but I truly believe that the protease inhibitors have a role. There is a benefit in selected cases, patients with comorbidities, patients with a high risk of progressing of their disease. They should be used early. I think that's the key. Within the first 3 days is the ideal window. Within the first 5 days would be good. 7 days, you're kind of pushing it. Beyond that, not sure how much, because the active viral replication phase, unless a person is immunocompromised, generally has ended by that time. And what we are seeing is the chronic effects of the immune response thereafter. So that's the first part of the question. What was your second part of the question?
Is it available in India?
So as I said, off-label. So the infectious
Off-label, right.
disease colleagues that we know and have been using it, because for HIV the drugs have been available, right?
Right.
So off-label in very similar dosages. I have had some colleagues who've used it, but I think people have stuck largely to using. Though I know that this is a very controversial area, but they have stuck to favipiravir, which kind of fell out of favor, and then molnupiravir, which has really been the one that has been largely used now in the Omicron variant wave when it has been required. I still know that people have been using Anandavimab, Casirivimab, which we know doesn't work in the Omicron variants, but still that has been used. I think that's not judicious use. We don't have the Sotorivimab, which we really know works. We don't have that here in India, so that's a downside. But I believe that with good supportive care, with good metabolic care, with good where needed, as I said, use of the protease inhibitors, use of the molnupiravir, or where necessary remdesivir for whatever it's worth. I know it's still being used here. We can have some impact if used early on in the disease, and can make some difference, at least in the acute course. We don't know whether it will have an effect on the long haul though.
Yes, sorry. It comes actually, if you can see, in this kind of a packaging.
Right.
As you said, double, this thing. So they both are combined actually. And interestingly, I had to help a couple of my friends who came from overseas to get this medication.
Correct.
The Yale study from 15 June says it's rebounding, but two of these patients who were my friends, they really recovered and they could fly back actually. They tested negative after 2 or 3 days. And interestingly, when I went to pick for them with the prescription from one of my friend, I didn't have to pay actually, because at CVS, our drug store, it's just been given free actually. And
Wow.
sadly, in these kind of situations in India, they'll charge you 200 times when it should be free actually. But talking about the human life actually, but so it has been effective for 2 or 3 patients I've seen actually. But the Yale study says it's rebounding. So thanks for letting us know. Mm-hmm. All right. Sorry, Narayan, I took too long. Over to you back.
Any other additional panel questions from panel members? 30 seconds. This is the best time to ask Dr. Sitesh. If there is no additional questions, thank you, Dr. Sitesh. And I'm seeing a lot of excellent feedback, excellent talk, very informative. We are very pleased to learn a lot about this. Looking forward to more of this and learn from you and the rest of the group. With that, I'll pass it on to the team, Jodhpur School of Public Health.
Thank you, Dr. Narayana. You are a great moderator. Dr. Sitesh Roy, we would love to have you on our campuses at Purnima and also in Jodhpur. And I think it's been a great talk, a lot to learn from you. And I would ask my colleague Rahul to say a few words actually. And I'm sure he agrees with me that we would love to have you on our campus one of these days.
Sure.
Rahul, to you.
Hello, Sitesh sir. Good evening.
Hello, good evening.
And thank you so much for coming on board. Yes, we really want you to see on our campuses someday. Recently, we hosted Dipanjan sir also only a week back, only 2-3 days before. And I'm sure, we'll have a lot of, healthy discussions in and around COVID. So I was seeing the presentation, whatever I could gather, though I'm not from a medical background, but I tried to, grasp a lot of terminologies. I always flaunt at my home that, I've been, after every webinar, I become more learned. And, some people call me also Munna Bhai at my home. So,
Nice,
but
nice.
but these webinars are very insightful, and if one could just note down all the points whenever they attend a webinar, this will definitely add up to a lot of chapters, at least for a specific person to memorize and to register. And all of these things are very very much required in day-to-day life, at least to have that knowledge. So thank you so much, and we really look forward to see you on Purnima University campus someday.
Certainly, certainly. I'll look
Thanks.
forward to that also. And I have done some traveling. I have not been traveling a lot. I have a lot of requests, but I've been traveling selectively. And now that we have again another wave going by, I'm doing more webinars now than live programs. But I travel once or twice a month. So hopefully in the near future we will meet and we'll plan some program and some meetings and do some good work together. I am very thankful to what you all are doing and how you all are creating a cadre of individuals who really understand the impact of health from the public health standpoint, which is so important. We as physicians can only do so much, but when the entire perspective is looked at from the human uh, individual, the family, the community, the society, and the country at large, I think we come up with some very unique solutions, as we may say. So I think it's great what Dr. Anil has begun and what all of you all together as a team are doing. I'll be happy to be a part of it. Thank you.
Thanks. Thank you, everybody. And we'll meet again soon, actually. Sorry,
I'll request everyone just to turn on your cameras just for a minute and we'll have a snapshot of this meeting. Thank you very much. Thank you, everyone. Thanks a lot.
Thank you. Thanks, everybody.
Thank you. Have a good day.
Thank you,
Have a good
Sitesh.
night.
Thank you, everyone. Good evening. Bye-bye.